to be presenting some of our atrial fibrillation research that we've been doing, and also kind of walk through our current understanding of atrial fibrillation and refresh memory on this very important rhythm topic. And as we all know, the atrial fibrillation is a remarkably common diagnosis. It's estimated anywhere between 2.7 and 6.1 million people in the United States alone have this arrhythmia. It's clearly the most common arrhythmia that we see, and it increases with age, as we know. Approximately 2% of patients younger than age 65 have atrial fibrillation. In contrast, about 9% of people over the age of 65 have atrial fibrillation. And this is a classic graph of age versus incidence of atrial fibrillation, demonstrating that it's a relatively uncommon diagnosis at the younger years, but progressively, okay, that's the off button, progressively escalates as time goes on and becomes, after age 80, even a remarkably more common diagnosis. And this is a really interesting depiction of how common this diagnosis is. This is data from CDC indicating how often hospitalization with a diagnosis of atrial fibrillation is encountered across the United States. And this is per 100,000. So when we see these red zones, that means more than 10% of all hospitalizations in these regions have a diagnosis of atrial fibrillation. And you can see it concentrating and following the typical risk factors for atrial fibrillation: obesity, hypertension, and so on. And we see this across all kinds of health graphs, is that this portion of the country seems to be not keeping up as well as others. But you can see a concentrated pocket of red within the Twin Cities, so it's not like we're immune to this. It is a common diagnosis here as well. And in terms of risk factors for atrial fibrillation, high blood pressure accounts for the most common risk factor, anywhere from 14 to 22%. But the other risk factors which are known and described include, of course, obesity, and the increasing incidence of atrial fibrillation over the last 30 years. At least two-thirds of that increase is attributed to increasing obesity rates. Also, European ancestry itself is a risk factor for atrial fibrillation. And then our other well-known ones of diabetes, heart failure, hyperthyroid, kidney disease, heavy alcohol use. That means more than 3 alcoholic drinks per day are associated. So 1 or 2 is not associated with atrial fibrillation. Enlarged left atrium, enlarged left ventricle, both of those are associated. And of course, obstructive sleep apnea, which is such a common diagnosis that we see nowadays. And the costs and the consequences of atrial fibrillation, above and beyond just the incidence, are truly quite impressive. And as I discussed, more than 750,000 hospitalizations each year for atrial fibrillation. The condition is estimated to contribute to approximately 130,000 deaths per year. So it's not a benign condition for many. And the death rate from AFib as the primary or contributing cause of death has been rising for the last 2 decades. So this, when we see on death certificates, we're seeing that atrial fibrillation is going up and up in terms of how often we're seeing that on the death certificates as a contributing cause. And the costs are estimated at about $6 billion per year. And medical costs for those that have atrial fibrillation are estimated about $8,700 more per year than if you don't have atrial fibrillation. So it is a costly diagnosis comparing the two.
Sorry.
One more glitch. So as we think about atrial fibrillation, it's certainly a condition that is frequent and seems to be growing. And mortality rates are higher with the diagnosis of atrial fibrillation. There's a couple good studies very large studies, very large population studies looking at mortality rates and have clearly established that atrial fibrillation is associated with a much higher rate of mortality compared to not. It's anywhere from 50% to 80% higher if you have a diagnosis of atrial fibrillation. And for cardiovascular mortality, it's 2 to 3 times higher death rate compared to not having the diagnosis. And this was consistent across several large studies, including the all-hat hypertension trial. So the treatment goals for atrial fibrillation really fall into 2 categories. One is to prevent adverse consequences, and the other is to treat symptoms as best as we can. And in terms of preventing adverse consequences, really the only thing that we focus on predominantly in clinic, of course, is prevention of stroke. And we do that by scoring them on the CHADS-VASc scale and then saying whether they need to have anticoagulation or not. And this is the data that supports the use of the CHADS-VASc score, and this is the annualized rate of stroke based on your CHADS-VASc score. And at a score of 2 or higher, they are indicated to be on anticoagulation, warfarin, or one of the newer anticoagulants. And you can see the rates escalate quite a bit as the numbers get higher. So about each one of these in the normal operating range that you and I see day to day, CHADS-VASc score 1, 2, 3, that equates to about 1%, 2%, 3%, 4% per year as a kind of a rough rule of thumb when you're talking to patients. Once you get above this score, then it starts to escalate. But in the normal operating range for 95% of our patients, you can at least say your CHADS-VASc score is 3. You probably have about a 3% chance of a stroke per year. It's kind of a handy way of remembering and talking to patients. And in terms of the new anticoagulants, of course, personally, I've shifted many patients over to this as long as financially they can, insurance coverage and so on. But the data behind the newer anticoagulants versus warfarin, it's interesting data. This is the trial of warfarin versus apixaban, and clearly it shows that in terms of patients with events of stroke or embolism, there's less of it in patients with apixaban versus warfarin. The difference here is not staggeringly large, and it translates the number needed to treat. You have to treat 300 patients with apixaban versus warfarin to prevent 1 stroke, 240 to prevent 1 death. So it's better, yes, it's better, but it's not dramatically better. And the number needed to treat here for major bleeding, it is better. Major bleeding events are less on apixaban versus warfarin. But again, the number needed to treat is about 100 patients with apixaban versus warfarin to prevent 1 major bleed. So it's a better drug, but it's incrementally better, not dramatically better. I think it focuses more on cost, and it's much easier to use, of course, these newer anticoagulants than warfarin. The one exception is that if you have a patient where you cannot keep their INR in range, they're high and low, that is a very different kind of a patient. And they're much higher risk of embolism, much higher risk of stroke if they're out of range frequently. So they actually probably would show in a study much bigger comparative benefit to the newer anticoagulant. And aside from anticoagulants, in terms of medical therapy, there's really no other definitive study that shows there's any other way to prevent any of the other complications. So anticoagulation is kind of the cornerstone because that's what we've got. And there's one exception, of course, if patients with rapid atrial fibrillation, rapid ventricular response, if they are left that way, they will go into heart failure and have higher mortality. But with that caveat aside, the other methods for treating so far have not shown mortality benefits. And the treatments really over time have evolved from one of, decades ago. It really was just a rate control strategy predominantly. There was not much in the way of, or any antiarrhythmic therapy for quite some time, up until the introduction of antiarrhythmic therapies in the 60s and 70s. So that once that started, it was really the dawn of the antiarrhythmic drug era, and that continued up until about 10 years ago. And over the last 10, even 15 years, there really has not been much development of new antiarrhythmic drugs. We haven't seen much since Multac came out. What was that, 2005, 2006? And we hear about studies of antiarrhythmic drugs for acutely converting atrial fibrillation, but not a lot about drugs to chronically treat. And that's predominantly because these studies are remarkably costly to develop. You have to prove that they don't cause proarrhythmia. And so these drugs are very expensive. It's a relatively small niche market. So I don't think we're going to be seeing a lot of new drugs moving forward. And kind of concomitant with the drug therapies, the new ones tapering off, is really the dawn of ablation to treat it, and ablation has proven to be a much more effective treatment compared to that. I just want to touch a little bit on rhythm control just for a moment, which we all know the classic trial, the Affirm trial, showing that rate control versus rhythm control did not show any benefit to mortality in these patients. If anything, the mortality was trending towards worse in the drug or in the rhythm control arm, and this was in a trial of rate control with beta blockers, calcium channel blockers, DIG, versus antiarrhythmic therapy to maintain sinus rhythm. So we know that antiarrhythmic drugs don't prevent mortality. And they didn't prevent, there was no difference in terms of stroke rate, in terms of death rates. And hospitalization was actually more frequent in the drug arm versus in the rhythm control arm versus the rate control arm. So we didn't have a lot of data up for any true benefit. In fact, antiarrhythmic drugs from that perspective may even be worse in terms of hospitalization. Now this, in terms of other therapies to try and reduce mortality, this is the most recent data that we have, and it's yet to be published. This was a Cabana trial, and this was a trial of drug therapy versus ablation for treating atrial fibrillation, and the primary endpoint was mortality rate. And what they found is that in the overall trial, there was no difference in mortality rate between treating with drugs and treating with ablation. So another therapy, at least this one in this form, showed again we're not making headway in terms of the mortality rate with this. And in terms of serious endpoints, death, stroke, bleeding, cardiac arrest, really again no difference between ablation and using antiarrhythmic drugs in the overall group. So we didn't, again, come out with a therapy that we could use to say, all right, we can do this and reduce your risk. Now, there was a couple caveats that I'll just mention in this trial. I think kind of the silver lining of the caveats to the trial, and I like this because it at least shows some hope for this, and that's that there was a lot of patients in the drug arm that underwent ablation, 27%. There was a lot of patients, to my mind, in the ablation arm that didn't get an ablation. So between the two, you've got 38% of patients where they didn't get the therapy that they were intending. So if you look at just how did they do if they got an ablation, how did they do if they just got drugs, that did show a substantial improvement. Mortality was reduced by 40%, from 7.5% to 4.4%. Death or CV hospitalization was reduced by 33%, from 74% hospital to 41%. These are big changes. You don't need very many patients to see that benefit. And there was a 47% reduction in AFib burden with ablation versus drug. But the other caveats to this trial is that this was started 5 years ago, and ablations at that time were not as effective as we would hope them to be. And only 50% of patients who got an ablation were free of AFib, only 50%. That's not a big number, and be seeing benefits even when you only got rid of it half the time. That shows some silver lining here. And the other takeaway is that only 25% who were given drugs after about 2 years were free of AFib. So when you give an antiarrhythmic drug, I don't oftentimes tell patients this, but there really is only about a 1 in 4 chance they're going to be free of AFib over the next 2 years. Now, it may be that they're much better, and that's sufficient. And maybe they still have an AFib here or there, and they're comfortable with that. So that doesn't mean it's not a good drug. It just means you can't tell them you're going to have no AFib very often. And for symptom control, I'll just bring up one important trial that still, I think, comes up in our minds, and that's when we say, all right, we're going to leave someone in atrial fibrillation, where should their rate control be? And this was a very nice trial comparing a strict versus a lenient control, and it was either resting heart rate less than 80 beats per minute or resting heart rate less than 110 beats per minute, and there was no difference in terms of symptom control, in terms of risks. But what they did find is that patients that were given very strict rate control were more often hospitalized, presumably because you give a lot of beta blockers, calcium channel blockers, and then they're bradycardic and hypotensive. So the takeaway is that symptoms should be your primary goal. It's acceptable if they come in the clinic and the heart rate's in the 90s, if they're feeling great, even up to 100s, and they're feeling well. This is just another study looking at antiarrhythmic drug efficacy over time. So we see that as the years go by, even amiodarone at 5 years is only about a 40% likely to be still working. All the other drugs, one sees in Sotalol, are below or hovering around 20% likely to be working. So our antiarrhythmic drugs are not effective. It makes sense as to why Affirm didn't show a difference, because you have so many patients on antiarrhythmic drugs still with atrial fibrillation. So that brings us then into the transition now out of antiarrhythmic drugs and into ablation therapy as an option to treat it. And really one of the first important trials was about 8 years ago now, and that was a direct test of ablation versus antiarrhythmic drugs in terms of freedom from atrial fibrillation. And that showed a significant improvement in freedom from AFib in this trial with 66% at, this is 9-month follow-up, versus 16% at 9-month follow-up in the antiarrhythmic drug arm. So the takeaway is that's not as good as we would want it to be, but that's what the data was 8 years ago. That's what the technology allowed. And the other takeaway is all these patients had failed one drug in order to get into the trial. So if you fail one antiarrhythmic drug, you have a 16% chance of another antiarrhythmic drug working for you. So it might work, but it's not a very, very likely scenario. It may work well enough, but free from AFib is not likely. So in terms of at MHI, we've been contributing, I think, a lot to the advancement of these ablation therapies, trying to get from that 66% 1-year success rate to something that's more acceptable. And this is one of the first trials that we were participating in several years ago. And in that trial, there was 17 major centers. We were one of those 17 major centers. And it was a trial of a new ablation technology called contact force that gave feedback in terms of how much contact the catheter had with the myocardium. If you have zero contact, you're going to have no ablation accomplished. And if you have good contact, you'll get a good ablation. And what we found is that in that trial is if less than 80% of the time, if the catheter didn't have good contact, then our results looked exactly like that first trial, 66% 1-year success rate. But we did find if there was good contact, now we got an 81% 1-year success rate. And we were one of 3 centers of 17. We, as a group, I'm very proud, we had the highest success rate in the entire 17 centers in the country. We had an 88% one-year success rate. We were one of 3 centers that allowed this number to be generated. Otherwise, they wouldn't have even had this data. All the other centers were hovering around 70% success rate. So it was really neat that as a group we had able to contribute that knowledge. And so that we got those results. This was about 2016, 2017 that this was published. We started using the catheter in about 2014. And since then, we've done a lot of research developing new methods to further improve our success rate. And looking at how to map atrial fibrillation, looking at better technology, better catheters to continue to escalate that success rate. And I think the goal for us is to say, well, if you've got an SVT, you're going to get 98% success rate. If you've got AFib, you're going to get 98% success rate. That is really, long-term, that's our ultimate goal, is to say that we can achieve that. And we've been doing some research looking at how do we identify and how do we better ablate atrial fibrillation. And I just want to touch based on, well, what is the mechanism of atrial fibrillation? It was originally proposed many years ago by Dr. Moe, 1959. He was the first one to develop a theory of atrial fibrillation. And that was that there's multiple wavelets propagating through the atrium. And these are independent, and you have to have a certain number of them in order to keep AFib going. So you imagine all these circuits, these reentrant rhythms propagating, and it's necessary to have the right number and have to maintain atrial fibrillation. These wavelets are constantly changing, they're constantly moving, they're not anything stable. And this was experimentally confirmed in 1985, so that was the first time that we knew, at least had a theory as to what was happening with atrial fibrillation. And the factors that allowed atrial fibrillation to develop that we understood at that time were atrial size. You had to have a big enough surface area to allow these reentrant pathways to develop. And we also knew that you had to have a lot of heterogeneous conduction velocity and tissue refractory periods that allowed for these to start. You can't get this in a normal, healthy atrium. It is something that's pathologic that develops in terms of the electrical properties. And it was this information that led to the development of the Mays surgery, segmenting the atrium to smaller sizes so that there was not sufficient surface area to allow for the atrial fibrillation to continue. And that actually was a reasonably effective treatment, simply slicing the atrium and sewing it back together. They were getting about 90% success rate for treatment of atrial fibrillation. The next big advance in terms of understanding atrial fibrillation was in 1997, where Dr. Hasagera in Bordeaux, France, had observed that atrial fibrillation was triggering from specific areas of the heart. And the areas that it was triggering from is predominantly the pulmonary veins. And this is a graph of each one of these is where he saw a trigger in this patient group. There was just a couple from the right atrium. Almost all of them were from the left atrium, right around the pulmonary veins. So this led to a major study that was published in 1997 describing ablation of the pulmonary veins to eliminate atrial fibrillation. And this really shifted the focus of ablation away from this Mays surgery concept to more of a triggered concept. So the idea is to ablate the triggers for atrial fibrillation versus eliminating the substrate or segmenting the atrium. And with trigger ablation for atrial fibrillation, just focusing on the pulmonary veins, as I mentioned, we can achieve about an 80% 12-month freedom from AFib. And the difficulty, of course, has always been in persistent atrial fibrillation, where it's a much more advanced form of atrial fibrillation. It's both triggers as well as substantial alterations in the myocardium that allow for atrial fibrillation to propagate. And the differences between these two are dramatic in terms of how often the ablation works. When we ablate the pulmonary veins in paroxysmal atrial fibrillation, we get about 80% success rate, but in persistent AFib, it's only about 60% success rate. And it's very likely this is due to the presence of all these additional sites that are causing it. And this distinction is very important clinically. When you see a patient that their AFib is self-terminating, you can have a very good expectation that an ablation is going to work pretty well for them. But if you have a patient that goes into AFib and they stay there and they will not come out on their own, that shifts in terms of what we've traditionally been able to achieve success rate with the ablation. And the atrial fibrillation, in terms of these factors that are allowing it to happen, this is a really nice diagram now that was developed by Alessi, looking at how reentry starts. And reentry is a condition where you have a fixed scar or a barrier around which a wavefront of electrical activation is occurring. And in this theory, we see this in atrial flutters. This is what happens. There's a gap between the activation wavefront and the wave tail. There's what's called an excitable gap that's present. With atrial fibrillation, a different mechanism is occurring. There is reentry going on, but it's different. It's a reentry where the wavefront and the wave tail are on top of each other, and there's no scar in the middle. It's simply that this is rotating around and the electrical activation is proceeding to the center and depolarizing the center and creating a functional area of refractory tissue allowing reentry. And this was well demonstrated by Alessi that this functional reentry occurs. And this actually was the theory behind what they thought these wavelets were, is that there was functional reentry moving through the atrium in multiple areas. Further research, though, in the early 90s showed that something different is actually happening than that traditional model by Alessi, and that is that there is an unusual form of reentry termed a rotor. And this is a form where it's not a true circle. We've got a wavefront and a wave tail meeting at what's called a phase singularity, and that is rotating around a refractory core. And this, I've got a nice animation of this. Hopefully it plays for us. Yes. So this is nice, even propagation across a substrate. You see a premature beat, and then we get what's termed a rotor developing. You can see how it moves and wanders. It's not fixed in one spot. It's not like there's a scar that it's moving around, staying in one area. But this is happening. And then as time goes on, this then develops into what we see actually in real atrial fibrillation. In real atrial fibrillation, we see that these rotors then have broken apart. There's multiple of them. It's very chaotic. You look at that and you see there's no possible way you can map that. It's just completely chaotic. There's rotors forming and extinguishing all through the atrium. And that is really what we're seeing in atrial fibrillation. In terms of efforts to map these, there's just been a few efforts to map in the lab. The first one was in 2012. Dr. Narayan had described a new technology that he was using to map these rotors, and initially had some good results. It was a small trial, 92 patients. About 72% were persistent AFib. The others were paroxysmal AFib. And they found 86% of the time they could terminate the AFib by ablating these spots in the lab. And then they found they had an 82% freedom from AFib after a single procedure. Now that's compared to 60% for the paroxysmal. And the other methodology, it took 5 years before we heard any other methodology, and that was last 2 years ago. Dr. Seitz in France had described a different mechanism of mapping these called spatial temporal dispersion. And that, again, was a small study, 96 patients. 77% were persistent, and they saw a 95% termination of AFib in the lab. So again, that's good evidence that they're ablating the rotors of atrial fibrillation, otherwise and terminating. They had reasonably good, they had an 89% single procedure freedom from AFib, 55% single procedure freedom from AFib or atrial tachycardia. So they were getting better in terms of their atrial fibrillation freedom by ablating these other sites out and beyond the pulmonary vein. And this is what dispersion looks like. You can see it's just all chaotic, just like if you were to imagine that map of all these different rotors extinguishing, and you're going to get electrical activation, which is just chaotic. And this is what it looks like. There are areas of the atrium, though, where there's no dispersion, and it's all lined up. So that's what regions that are not dispersed look like. And what we've been doing here at MHI over the last 2 years is to try and map these rotors, develop new methods of mapping them, which may be complementary to some of the findings of these investigators. And the methodology we found that's been working best so far is what's called ripple map. And ripple map is a method of displaying this complex electrogram as a point on the map. So every time the electrogram moves from baseline, this point will show a deflection. So we can map complicated electrical signals no matter where they are. And this is what it looks like in a standard flutter rhythm, where we can see activation breaking across the mitral valve and moving it over the left atrial roof. So this is what it looks like in a standard rhythm, and it's been a remarkably effective tool for mapping standard atrial flutters, much better than we ever have had, and it certainly improved the success rate for atrial flutters quite a bit. And what we've worked on is a methodology of using this form of mapping for atrial fibrillation. And there were some benefits that were pretty obvious from the beginning as to looking at this methodology. One is that we could look at the entire atrium, the whole left atrium, the whole right atrium. All of our other methods were just looking at one electrogram here, one electrogram there. It was not a comprehensive evaluation. And it allowed for taking a lot of activation points, really high-density electrical maps to try and find these. And it was something that we actually already had. It had been released for mapping of atrial tachycardias. We've got the catheters. We have all the tools in hand. So it was just a matter of trying to see if this would work. And kind of through this research, regions called, which I've termed HYPRAs, or high-frequency ripple activations. These are sites where the atrium are continually activating through time as a site to potentially indicate rotor sites. And the hypothesis going into this research was that regions with HYPRA would correspond to bipolar electrograms demonstrating this spatial temporal dispersion that was observed by Dr. Seitz. And that the other was that ablation of these sites would actually terminate AFib and then lead to some improved outcomes of these patients with persistent atrial fibrillation or paroxysmal, for that matter. And this is an example of a patient that I had brought to the lab. Now, he had a history of a prior pulmonary vein isolation procedure 5 years ago, and now he came back with recurring atrial fibrillation. And I brought him to the lab, and I put him on isoproterenol, and what we see here is that a sudden burst of activity, here's sinus rhythm, sudden burst of activity indicating this is the trigger going into atrial fibrillation. We see that he's got a trigger. I observed a left pulmonary vein had reconnected from the prior ablation. And that was the source of his recurrent trigger. But once he had triggered into AFib, he stayed in atrial fibrillation. So it transitioned from that triggering mechanism from the pulmonary vein to these rotors that are developing within the atrium. We decided to map this AFib that was still ongoing to see if we could identify where it's coming from. And this is what the ripple map looks like. And what we saw is that there was two sites of here and here of this continuous activity. And we didn't see that elsewhere in the atrium. And those look to be good targets for rotors. And sure enough, ablation of these two areas led to this atrial fibrillation slowing and then terminating to sinus rhythm. And then after that, no matter what I did, I couldn't restart atrial fibrillation. So we had gotten rid of the triggers by isolating the pulmonary vein. We got rid of the rotors by ablating these two sites identified on ripple map. And then their AFib is gone, and we couldn't restart it. Here's another example of a ripple map. This is one where we've got a driver, a rotor located in the left pulmonary vein antrum. So here's the left pulmonary veins, right pulmonary veins, and this is what they look like. And you can see, again, continuous electrical activity in the right pulmonary vein antrum. That's clearly a source of atrial fibrillation. So we've been doing this now for the last 2 years, and we look back at our data as to how are they doing. I could see and what are the outcomes. So this was a ripple map study, 161 patients, and this was the first time ablation for persistent AFib. We had 56 patients in the ripple map guided approach, and then 105 in our old approach, the standard approach that we used to use. And the ripple map approach is pretty straightforward. We just would ablate to isolate the pulmonary veins and then ablate these hyphrocytes to eliminate the rotors. And what we saw, here's the baseline characteristics were fairly similar. This was a retrospective study, so there was a difference in the gender, and so that we had to account for in our modeling. But overall, they were pretty well matched in terms of baseline characteristics. The important ones is that the EF was no different, the left atrial dimension was no different, the diabetes, hypertension, structural heart disease, those big factors for risk of recurrence were no different. And in the lab, we saw, we got acute termination of atrial fibrillation in a very high number, 95.8% in paroxysmal patients and 91.4% in persistent patients. So really nice results, higher than reported by Narayan, in the ballpark of what was reported by Site. And most common, there was 4 of these Rotors sites identified. That was the average in persistent, and 2 of them identified in paroxysmal. Well, the results at 18-month follow-up, this is our single procedure freedom from atrial fibrillation. The red is the ripple strategy. The kind of the light blue is the standard stepwise approach we were using. And the results are truly remarkable. We're at 98% freedom from AFib at 18 months. So they're not having AFib. And that's the highest ever reported in any study. And hopefully I can get that published. But it's really, I was very happy to see that going on. We were doing pretty good before. We were getting somewhere around 80% success rate from a single procedure before. That's still pretty good, higher than most centers, but this is really a nice improvement. And this difference did remain after adjusting for those baseline differences, gender and hypertension. Now this compares to, this is the biggest randomized study that we currently have that was published not too long ago on persistent AFib. And these are the results they're seeing at 18 months. 60%. This is the current state-of-the-art guideline methods. So this is dramatically better than this standard method. So there is still more work to do, though. What we're observing is that the AFib is gone, essentially gone, but we are seeing still a lot of atrial tachycardias developing after the AFib ablation, flutters and atrial tachycardia. So about a little bit less than half, but 53% of them were free of atrial tachycardia. So I've got some ideas. We've got some ideas as to how to reduce that further. Importantly, though, when we looked at after an average of 1.4 ablations, freedom from AFib was 100%. Freedom from atrial tachycardia was 87%. And that was all the patients. If we look at the 19 who had recurrence of AFib or ATAC and got an ablation, then 17 of 19 were free of all rhythm issues after that. So after the second ablation, they seem to be predominantly doing quite well. But we're going to work on this, and I think we can get that single procedure freedom from atrial tachycardia up into that range as well. So we've had good improvement, and I think we've been contributing as a group nicely to the national dialogue and the success rate starting at the 65% and now moving towards above 90% success rate as years have gone by. And so looking towards the future, what we'll be working on is, first of all, this methodology of ablating the rotor sites, improving the accuracy of mapping. So we'll have the manuscript on the retrospective data finished. It's nearly complete, and then we'll get that published. And then we've got, I've been working with some engineers in Israel developing a new software method of mapping this. So you look at those ripple maps, and there's a lot of chaos going on, but I think we can distill that to essentially the red zone is where it's at. And then we can take that into a multi-center trial using that new software, and we've had a lot of interest in moving in that direction, so I'm hopeful. I want to bring up just a couple other studies that we're doing right now, and then we'll close. The first is right now we are enrolling in a very interesting study. It's called SurePoint, and SurePoint is a new method of assessing how the lesions are developing. And this is a national multi-center study, paroxysmal atrial fibrillation, and failed one antiarrhythmic drug. And when we think of ablation, it is a keying methodology, and the keying results in regions being destroyed. The hope is permanently. That's the intention, is permanently destroyed. The difficulty right now is we don't know how big the lesions are. If you're on for 20 seconds of ablation versus 60, we know that it's going to be a bigger lesion, but we don't know how big. We don't know, how deep is it? Is it 3 millimeters? Is it 8 millimeters? We don't know. So this depth and size of lesion, we have not had any tools to estimate. And SurePoint is a new tool, a new method for accurately estimating the lesion size. And that's the first ever software that's been, or method that's been available to do that. So I think that we may see that we've got even more durable lesions than we've had before. So that's what I'm expecting. And this is a test of that, and we'll ablate to specific lesion sizes around the pulmonary veins and see how they do for a year. My expectation is we're going to see nice success rates for using that. And the next study that we'll be up and running with in about 2 months is called the QDOT study. This is a really cool new catheter, and it's the first catheter we've had that gives us a measure of tissue temperature. And when we're ablating, we're trying to reach 52 degrees centigrade. That's lethal tissue temperature. But again, we haven't been able to measure that in any way. And because we can't measure it, sometimes the tissue overheats. And when it overheats, this is what happens. You get it heating at the tip, and then all of a sudden, it overheats, and we'll get an explosion. And that's a steam pop. That's because the tissue reached 100 degrees centigrade, it boiled, and then exploded. And this is a safety concern because when that happens, it can immediately rupture the myocardium and create a pericardial effusion, perforation. So being able to know that temperature, it could be a nice advance in terms of safety. So this new catheter allows for temperature assessment. And when this new catheter, because it measures temperature, it's got a Q mode where it will automatically drop power, increase the flow to cool it off to prevent that complication from developing. So that's first ever catheter available that's going to have that available. And the study, it also allows for another interesting methodology, and that's that turning on, because it can measure temperature and improve safety, they found that they can ramp up the power. Typically, we're giving about 35 watts of power to ablate. They found they can go up to 90 watts of ablation and turn it on for 4 seconds and get the same lesion as I'm getting at 35 watts for 30 seconds. So you can imagine 4-second ablations versus 30-second ablations. The procedure goes a heck of a lot quicker. And they found in Europe that their ablation times were reduced from 2 hours to 45 minutes. So that study will be up and running hopefully then sometime in March. So that's really exciting development too. Now that explosion is dramatic. So Afib is common. As we know, anticoagulation for stroke. No treatment definitively reduces mortality, although there's some possibility that ablation will, especially if we get 90% success rate. I think we can see some mortality differences. For symptom control, ablation is more effective than drugs, and with current research, we're on the road to getting better results and improving the treatment for this. Thanks so much.
Before questions, I've got a quick announcement for the people who dialed in on the phone. If you have a question, you can press *6 to unmute yourself and jump in between the live questions here.
Could you comment on procedural safety, the experience we have in our lab versus also experience, sort of comparing it to national?
Right. So thanks for bringing that up. Our experience locally, I think I'm very proud with how we have all been doing in terms of safety. Compared to the national, we are dramatically lower in terms of risk. So the risks of stroke, esophageal fistula formation, perforation, our rates are running remarkably low, somewhere in the 1 in 500, below 1 in 500 rate, whereas nationally, those will be running between 0.5 and 1%. So we're doing really good, and I think at being careful with these procedures, and all of us do a great job that way in terms of safety. So it has evolved that way, I think, away from a procedure that I think of as having high risk. Yeah. Yeah, David.
Dan, in the Cabana trial, I suspect that they used anticoagulation throughout. Can you comment on discontinuation of anticoagulation following ablation? I've certainly seen that done, and I just don't know if there's any supportive data in that area.
Right. Currently, the recommendations are to follow the CHA2DS2-VASc score. So if you're 0 or 1, no problem, you can stop after an ablation because they really may or may not have needed it to begin with. Patients that are CHA2DS2-VASc 2 or higher, the current recommendation is to continue anticoagulation, even if the ablation looks to be effective. I think within a little reason, I think most centers across the country in a CHA2DS2 might say give them 6 months. If they're paroxysmal AFib where the success rate is very high, talk to the patient and maybe together you decide that they want to come off of it. CHA2DS3 and higher in a persistent patient where recurrences of flutters and so on are common, I wouldn't recommend it. I would say stay on it for now. There's no data so far that ablation reduces stroke rate. I think in order to get that data, we need procedures that are reliably 90% or higher freedom from AFib before, and that's, I think, when we'll start to get some data, but I don't foresee that in the near-term future. Yes, Scott.
Could you comment on the mechanism of these post-ablation atrial tachycardias that you're seeing, and how do you manage those?
Yeah, I think, well, the mechanism is twofold. One is that they can't have AFib anymore, so their atrial tachycardias that would trigger the AFib before don't. So they just show up with an atrial tachycardia. The other is that certainly the ablation results in slowed conduction in areas and enhances development of flutter. So sometimes it's a new area that simply revealed itself because it doesn't trigger their AFib anymore. Others, it's a consequence of the ablation. Management of it, typically I would recommend to ablate it because it's a high success rate, and you can tell them 90% of the time then you're free of everything. So they're very common in the first 6 weeks after an ablation, so oftentimes we'll cardiovert and put them on a drug, trying to just allow the heart, the inflammation to diminish and give them a good 3 months of remodeling before taking them to the lab. So usually in the early stage we're cardioverting and we're increasing antiarrhythmic drugs or putting them on one. After 3 months, if they have recurrence, then ablation is a good option. The one caveat to that is that there's patients that they're fine for 5 years and then they come in with flutter 5 years after their ablation and we cardiovert it and then we'll just watch and see if this was kind of an isolated episode. But I would say if they've opted to the ablation route, then you probably want to take it to a second ablation, take it to completion if I can. Yeah.
Great talk. In structural heart disease, we're doing more and more procedures transeptally.
Mm-hmm.
So I can see maybe in 4 or 5 years we'll do more transcatheter valve replacements. Obviously, older people, usually they have maybe permanent AFib. But nevertheless, the question every now and then comes up, even with PFO closures. If someone has this history and we have a closure device at the atrial septal area, is it an issue for you guys, or is there a certain closure device between maybe the Gore and the St. Jude devices that doesn't cause an issue, and should we have consultations? Because I can see that might be an issue for you guys to cross, or maybe it's not. And number 2 is, I think we were just invited to do the option trial at some point. We'll have to talk, of course, with Steve a little bit more about it. But so ablation procedure and then a Watchman device right afterwards, so that you may not need anticoagulation at all anymore. Once you're in there, basically kind of close shop. So that might be another.
Yeah, I think it's interesting. And in terms of the PFO ASD closures, typically we can get around them. We can go below it. Puncturing through it is not a good plan because then they're left with something that will not resolve. But we've done many through the years with the different, and haven't seen a big, one that's dramatically better than another. So I think you pick one that's best for the anatomy and what you think, and we can work around it typically. And yeah, that trial's interesting. It's an interesting thought. You're in there already. Should you put in a Watchman at the same time? Yeah. So we'll see. That's a neat trial. Yeah. All right.